Alright, this is the nervous system part 3 on these very shitty whiteboards. I'm just going to start calling it that, shitty whiteboard, anatomy and physiology. Anyway, I didn't get all the whiteboards from class, but it's going to be as good as it's going to get. So this is going to be all the material for your week 11 quiz for Anatomy 216, for whatever school this is. Okay. So this is going to cover initially the meninges. So on the left, this is going over basic motor and sensory pathways, which were on the last quiz. So we don't need to talk about that. On the right, this is a depiction of the brain. Yeah. So the brain here. And then the spinal cord, which is definitely not drawn to proportion in any way, shape, or form. So the meninges. So 3 layers. Outer layer, here's the dura mater. This is a very messy whiteboard. So this is underlying the skull. It actually splits into 2 layers at the superior aspect of the brain, and that's where we have this superior sagittal sinus running from anterior to posterior, filled with venous blood, and that's where we get we get absorption of cerebrospinal fluid into the venous blood. So we're constantly making cerebrospinal fluid, so we have to be constantly absorbing into the blood to maintain that roughly 140 milliliters volume of CSF. And remember, the 3 things that affect intracranial pressure are the mass of the brain, the volume of blood in the skull, and then thirdly, the cerebrospinal fluid. So we cannot have too much cerebrospinal fluid because that could lead to things like hydrocephalus and increased intracranial pressure, and we don't want that. Okay, so sorry, dura mater. Underneath the dura mater is the arachnoid mater. Then we have a space, that's where these arrows are, going around the brain and the spinal cord. This is the subarachnoid space. This is where we find cerebrospinal fluid. Okay. On the innermost layer, the pia mater, this is clinging to the surface of the brain. So where is cerebrospinal fluid made? It's made in here, these lateral ventricles, which used to be called the first and second ventricle because we have a third and a fourth ventricle. So that would make sense, the first and second, but now we call them lateral. There's an area called the choroid plexus, which has a density of cells called ependymal cells, which are neuroglial cells. If you remember, these are support cells. So neuroglial, like nerve glue. Glial means glue, I guess. So they're made in the choroid plexus by ependymal cells in these lateral ventricles. It gets drained through this little tube called the foramen of Monro into the third ventricle, which is actually in the diencephalon. That's between the hypothalamus and thalamus. This drains to another little tube called the cerebral aqueduct to the fourth ventricle, which is in the brainstem. Then it drains out through 2 foramen. One foramen is called the foramen of Luschka, one's the foramen of Magendie. You don't need to know that. Not really important. And then it flows through and around the subarachnoid space right here, so subarachnoid space. And then we have little arachnoid granulations here. This is where the dura splits. One layer of dura attaches to the skull, one kind of invaginates here and follows the arachnoid mater, and then these little arachnoid granulations is where we absorb the CSF. So this is depicting also some brain bleeds. So there's 3 basic types of brain bleeds. I might as well talk about them while we're talking about the meninges. So here, an epidural hematoma. Well, epidural, it's outside the dura, so it's between the skull and the dura mater. Over here, a subdural hematoma. Well, sub means under, so between the dura and the arachnoid mater. And thirdly, a subarachnoid hemorrhage. That's when you have bleeding into the subarachnoid space. Down here is talking about water in the brain, or hydrocephalus. One of the main causes is spina bifida. There's other causes, and these people sometimes need a ventriculoperitoneal shunt. There are other shunts too, but I'm not a neurosurgeon, so I don't know the details on all those. Okay, so the spinal cord cut in half. This again is transverse section of the spinal cord here. Remember, the internal parts here are called the horns, and they're made of gray matter, so they're mostly neuronal cell bodies where we have synapses. Anterior horns here. Anterior horns are primarily motor neurons. Posterior horns are sensory neurons. And there's a lateral horn in certain places for the autonomic nervous system. Okay, then the outer part here is made of white matter, meaning this is all nerve tracts. So ascending and descending myelinated axons. So ascending means moving information up towards the brainstem. This is mostly sensory information, which is going to synapse in the thalamus and then go to whatever area the cortical and subcortical areas is supposed to go to. And then motor information is mostly descending, coming down through motor pathways, and then synapsing in the anterior horn with the lower motor neuron. Okay, here's some anatomy of the spinal cord here. Probably should talk about that first, right? So sitting atop the brainstem is the thalamus, because we know all sensory information synapses there other than the sense of smell. Then we have the three parts of the brainstem: midbrain, pons, medulla. And then we have the spinal cord. We have a cervical section, which is a little bit enlarged, and that's due to the cervical and brachial plexuses. So C1 through C8, so there's 8 segments of the cervical spinal cord. Does not correlate always with or exactly with the vertebrae. And so we're going to have 8 pairs of cervical spinal nerves. Thoracic spinal cord, T1 through T12, so 12 segments, so we have 12 pairs of thoracic spinal nerves. Lumbar, L1 through L5, so 5 pairs of lumbar spinal nerves. S1 through S5, 5 pairs of sacrospinal nerves. And then CO1 stands for coccygeal 1, so 1 pair of coccygeal spinal nerves. So remember that the tip of the spinal cord is called the conus medullaris. So this generally ends the body of the L2 vertebrae, which is very clinically relevant for reasons we talked about in class. And then these nerves hanging down here, which is very poorly drawn, is called the cauda equine. It's cut off, cauda equina, which means horse's tail. So those nerves have to continuously go inferior because they have to pass through the neural foramina between the lower lumbar vertebrae and the sacral foramina and form all these spinal nerves down here, even though the cord itself actually ends. Okay, then I should have talked about this. So yeah, anterior horns are motor neurons, posterior horns are sensory neurons, and then all the white matter, that is composed of all ascending and descending nerve tracts, because white matter we know is mostly myelinated axons. So this depicts a basic sensory pathway. So a sensory pathway, well, sensory information is afferent, so it's coming into the brain and spinal cord. So here's an example of a sensory receptor. So nociceptor could be a thermoreceptor, could be any kind of a pressure receptor, proprioceptor, internal like chemoreceptor, baroreceptor, all those things. Stretch receptors. And so we already know what a basic sensory neuron, the first order neuron, is attached. The first is attached to the sensory receptor. It brings information in, but towards the spinal cord. So here we have an anterior ramus and a posterior ramus. The posterior rami generally just provide innervation to the back of the head, the upper back, lower back, down to the upper glutes for sensory information and some motor control of some of the deeper spinal muscles. Where the anterior rami, they provide sensory innervation to the anterior surface of the body as well as all the musculature and structures of the limbs. So this is coming from the hand, let's say. So it's coming in the anterior ramus. It's going to then enter the spinal nerves. We know spinal nerves are composed of sensory and motor neurons. And it's going to go into the posterior root. So the posterior root is all sensory. Anterior root's all motor, which makes sense because the anterior horn's motor, anterior root's motor, posterior root sensory, and the posterior horn sensory. The spinal nerve, remember, it is sensory and motor neurons. So it's like a two-way street here. So some axons are coming in, some axons are going out. So this is generally going to synapse in the posterior horn with the second order neuron, and that is going to ascend the spinal cord through one of these sensory pathways. We have an anterior and lateral spinothalamic pathways, which take pain and temperature information for the most part. And these two back here are depicted as the posterior column medial lemniscal system, and this carries information about touch and pressure and things like that. And we're also going to have spinocerebellar pathways that brings sensory information to the cerebellum. So this is going to be the second order neuron, which synapses in the thalamus, with the third order neuron, which then carries on to whatever, in this case would be mostly the somatosensory cortex as well as the limbic system, which we've already talked about. That's a basic sensory pathway, okay, and what happens, the mechanics of what happens in the spinal cord. Now here's a basic motor pathway. Well, So this is going to be descending the spinal cord coming from the brain. So let's say it's from the somatic motor cortex. So we send signals that we want to contract a muscle. So this is going to descend in a motor pathway. We have anterior and lateral corticospinal tracts, which mostly control our skeletal muscles. It's going to synapse in the anterior horn. Now we're going to pass through the anterior root because the anterior root's all motor than the spinal nerve because spinal nerve's sensory and motor. And in this case, let's say it's going to a limb or anterior musculature, so it's going through the anterior ramus. Okay, which you guys don't need to know the rami details. Okay, now what about reflexes? We talked about reflexes. So there's two kinds of main reflexes, withdrawal and stretch. So withdrawal reflex here, so some kind of painful stimulus, you put your hand on a hot burner, you step on something sharp with your foot, that sensory information is going to come through the first order neuron here, through the spinal nerve, posterior root, synapse. It's going to send information up from a second order neuron to your brain because you're going to be aware of that pain pretty soon, right? But we want to withdraw from a painful stimulus, so we need to send this motor information immediately to move before our brain has time to process, but our brain will process it. There's still a thing called an interneuron, which connects the sensory and motor neurons. So this is going to directly connect the sensory neuron to the motor neuron, and then this will send information out through the anterior root, spinal nerve, anterior ramus, and then go to the muscles. So if it's your hand, the muscles that flex the elbow. So that would be brachialis, biceps brachii, and brachioradialis muscle, and withdraw the arm. I mentioned the cross extensor reflex in class. You don't need to get tested on that. The other type of reflex would be the stretch reflex. So this does not use an interneuron. I don't have a depiction of that, but it's the only difference. So when a muscle stretches, so if you drop down to a deep squat and stretch your quads suddenly, there's something in the middle of the muscle belly called the muscle spindle, which will send information back to the spinal cord, and it'll directly connect to a motor neuron and make the muscle contract. So if you suddenly stretch a muscle, it'll respond by contracting that same muscle. We see this when checking deep tendon reflexes. When we hit the tendons with little hammers, so like the biceps or triceps tendon for the upper extremity, the patellar tendon, Achilles tendon for the lower extremity, checking our deep tendon reflexes. And we talked about hyper and hyporeflexia for the material in the last quiz. And so that's basically stretching the muscle really quickly, just a little bit, and it causes the muscle to contract. Remember, these are involuntary, meaning the reflexes, they happen before we can process the information and consciously make an effort to move. Uh, so that's how those work. All right. So autonomic nervous system will be the last topic. So we talked about this is really a visceral motor system. So the somatic motor is controlling our skeletal muscles. What's controlling all the internal motor functions of our body? So cardiac muscle, smooth muscle, and glands, right? Even glands are controlled by the motor system. Think of sweat glands, and think of glands in the mucosa of the GI system as an example. So, but this is called autonomic, so it's automatic, right? We don't have conscious control over this. This is involuntary. So it's two divisions, sympathetic division and parasympathetic division. So the sympathetic divisions are, quote unquote, fight or flight. So this activates when we have a stressful stimulus, a potential danger to ourselves, or even just exercise, right? So these are two systems are balanced all the time. It's not like, oh, it's always fight or flight. It's some kind of life or death thing. Any kind of anxiety or stress, or public speaking, or just even exercise, which necessarily isn't, what we consider psychologically stressful, but it is a stress in our body. We need to increase our heart rate. We do need to increase our ventilation, so we have bronchodilation. We do need to reduce digestion, and things like that. The parasympathetic nervous system is our rest, digest, and really should add, reproduce, and eliminate because it's time to reproduce because you're in a calm state. Usually this is how, for sexual arousal, we need to have parasympathetic stimulation of those sacral nerves, S2, S3, S4 to the genitals to increase blood flow and secretions. And then also eliminate. So we're increasing digestion, but we're also time to eliminate, to go to the bathroom, right? Get rid of waste. So we're going to increase GFR or filtration by the kidneys to increase urine output, and we're going to be okay with having defecation reflex. So sympathetic nerves, don't really know the mechanics that much. The basic setup is the preganglionic neuron and the postganglionic neuron. So there's going to be a synapse outside of the central nervous system. There's acetylcholine release between the pre-ganglionic and postganglionic neuron for sympathetic and parasympathetic. I don't care if you need to know that. But then the terminal neuron, or the postganglionic neuron, which is going to directly attach to its effector, whether it's cardiac muscle, smooth muscle gland, sympathetic nervous system, you're going to release of norepinephrine, okay? And then parasympathetic division, you're going to release acetylcholine, right? The same neurotransmitter we use to excite skeletal muscle. And the real big thing here to know, especially when you move on to pharmacology, is all these receptors for the autonomic nervous system, right? Skeletal muscle is pretty easy, right? There's the acetylcholine receptor in the muscle membrane for skeletal muscle, causes contraction. But the different receptors have very significantly different effects. And that's where it gets very complicated. We start talking about drugs like sympathomimetic drugs. You talk about beta blockers. You talk about beta agonists. You talk about alpha blockers and alpha agonists. And then, for cholinergic drugs, a lot of times you call them, anticholinergic drugs if they're opposite of a cholinergic effect. So yeah, it's a good time. So real briefly, you don't need to know all these details. So for adrenergic receptors, they're called adrenergic in the sympathetic nervous system because they bind to adrenaline. Remember, we used to call epinephrine adrenaline and norepinephrine noradrenaline. And some other countries, they still use those terms. So hence adrenaline adrenergic receptors. Well, there you go. So alpha receptors, they cause contraction of smooth muscle. So this is something like the blood vessels in the peripheral vasculature. So that will cause vasoconstriction. So some drugs like alpha blockers, right, they will cause vasodilation. So we even use those for like urinary retention or people with BPH to increase blood flow. So alpha 2, this is confusing, are more so in the central nervous system, and they're inhibitory. So if you release norepinephrine and agonize or stimulate the alpha 2 receptors, you'll have a decreased sympathetic output. The best way I can explain this is the drug clonidine. People give clonidine, which is an alpha 2 agonist. Well, if you agonize a sympathetic receptor, you think of sympathetic output, but it's the opposite. That can be used for hypertension. It can be used for like withdrawal symptoms, or just decreases sympathetic output, so it calms people down. It's used for a number of reasons. That drug clonidine. Beta receptors. So beta 1 receptors, the most important receptors is by the number 1, are on the heart. So drugs like beta blockers, but what do? They reduce heart rate, right? They make the heart relax. Okay, so they reduce contractility and reduce heart rate. Obviously, these are important drugs. So the lulls, so metoprolol, nebivolol, all those drugs. There's a bunch of them. Propranolol. So beta 2 receptors. So this causes relaxation of smooth muscle. So we find this in airways and GI. Okay. So what does this mean? Think about a sympathetic output, which we're going to get to in the next 2 slides. You're going to have decreased contractions in your GI system, okay? But you're going to have constriction of the sphincters, and you're also going to have relaxation of the airways, so they bronchodilate. We relax those muscles. But then blood vessels can cause vasoconstriction, so we cause increased contraction of that smooth muscle. And then the heart, obviously, we're causing increased contraction of the heart muscle. So some muscles are going to be contracting more, some muscles are going to be relaxing. Great time. So, but it makes sense in the airways and the GI, want them to relax, right? So we're going to have beta 2 receptors there. But we're going to have alpha 1 receptors in places we want muscle to constrict. So like sphincters and blood vessels. That makes sense, right? And the heart, obviously, we're going to increase contractility. So we're going to make the heart squeeze harder. And then, so we call those things positive chronotropic, increase the heart rate, positive ionotropic, increase ion movement, basically for contractility. Beta 3 receptors, we find these in adipose tissue. We don't talk about this a lot because they're not really clinically that relevant, but there are drugs that can be beta 3 agonists and increase lipolysis, clenbuterol, which isn't used in the United States. Another example for a beta drug, so beta 2 agonist would be like albuterol. Okay, clenbuterol, albuterol in the same drug class. So albuterol, what that does, it causes your airways to bronchodilate, opens up your airways like during an asthma attack. But also speeds your heart rate up. So it's kind of interesting. Some of these drugs will bind to more than one receptor. So there's some overlap with some of these things. And if you understand that, you'll understand some of the side effects. So understanding these adrenergic receptors is actually really important. Now, cholinergic receptors, we have two kinds, nicotinic and muscarinic. So nicotinic are named after nicotine. So there's the N receptors, or the N2 receptors, I believe, are found in neurons. And the NM receptors, or the N1 receptors, are found on skeletal muscle, which we already talked about from the somatic nervous system releasing acetylcholine, which is not part of the autonomic nervous system. Okay. Then muscarinic receptors, we have M1, M2, and M3. M1 are found in the brain, so it's acetylcholine activity in the brain, much different than acetylcholine activity in skeletal muscle. So we see this especially in Alzheimer's disease. People have a decreased acetylcholine activity. So a lot of drugs they try to use for Alzheimer's are acetylcholinesterase inhibitors to increase acetylcholine activity in the brain. M2 receptors are on the heart, so obviously if we stimulate these, we're going to have negative chronotropic effects, meaning decrease the heart rate. And then M3 receptors are going to be found on smooth muscle, so this is going to cause smooth muscle to contract, so increase contractility of the esophagus, the stomach, the small intestines, the bowels, all that good stuff. So this kind of outlays what all these things are going to do. So knowing those receptors is actually really important. Okay, now I didn't get a sympathetic picture of this, so I really screwed up on this one, but so parasympathetic effects. So first of all, the parasympathetic nervous system is craniosacral, meaning this comes from a total of 4 cranial nerves and S2, S3, and S4 portion of the spinal cord. That's it. And it's going to cover the whole body. All right. So start at the top. So cranial nerve number 3, oculomotor nerve, is going to move to the eye. This is going to cause pupillary constriction because when we rest and digest, we don't need the pupil to be large and letting in extra light. Cranial nerve number 7, because this goes to 2 of the 3 salivary glands, sublingual and submandibular. Cranial nerve number 9 goes to the parotid gland, which is the other salivary gland. We're going to increase saliva production because saliva is part of digestion. It contains digestive enzymes like amylase, and it's going to lubricate that food bolus. Now, cranial nerve number 10, the big one, vagus nerve. So this is going to innervate the heart, the airways, and the lungs, the digestive tract, the kidneys. Okay, and the digestive tract, it cuts off right here. I mean, this little line at the splenic flexure. So that means it's innervating the esophagus, the stomach, the duodenum, the jejunum, the ileum, which are the parts of the small intestine, ascending colon, transverse colon, and stops right here. So it means the descending colon, sigmoid colon, rectum, some lower parts of the urinary system like the bladder and the urinary sphincters, the anal sphincter, not sphincter, and then some of the reproductive organs, that's taken care of by S2, S3, S4, but I'm not really that concerned about that. So heart, decreased heart rate, so negative chronotropic effects, slow the heart rate down. Airways, constricts the airways, so bronchoconstriction. So we don't need the airways wide open. We don't need that much air coming in. Digestive system, increased motility and secretion. So these are going to be those M3 receptors. And then relaxation of the internal anal sphincter. So external anal sphincter is skeletal muscle, it's voluntary. Internal is smooth muscle, so we'll relax that. And then the kidneys. So we're going to increase filtration. So increased blood flow to the kidneys will increase glomerular filtration rate, which will make more filtrate, and hence, depending on a few other factors, potentially more urine. And then we're going to have relaxation of the internal urethral sphincter, which is smooth muscle. The external is skeletal muscle. So you can hold it. Reproductive organs, we're going to increase blood flow, increase secretions, which all makes sense. Now, blood vessels and skeletal muscle in here because it's part of the sympathetic nervous system, which isn't drawn. So I'll talk about it briefly. First, gastroparesis. So that's just an example of malfunction of the autonomic nervous system, but specifically the parasympathetic nerves, because we'll have decreased peristalsis in the stomach, slowed gastric emptying, because food just sits in the stomach. So gastroparesis, stomach paralysis, stomach paresis, paralysis. People get nausea and vomiting, get real sick. Most commonly seen in diabetes. It's not really a good time. Need drugs like metoclopramide. Now, blood vessels and skeletal muscle, we'll see that those are affected more by sympathetic nerves because of vasoconstriction here and increased blood flow to skeletal muscle. Also, the adrenal glands, those are also sitting on top of the poles of the kidneys. Sympathetic nervous system will also cause adrenaline release from the adrenal medulla. So sympathetic nervous system is set up thoracolumbar, so it extends from T1 to L2. It makes all these splanchnic nerves. T1 to T4 or 5 go to the heart and lungs, and then the rest are broken down from the greater, lesser, and least and lumbar splanchnic nerves, which you don't need to know. Anyway, here's this crappy chart, because I forgot to put that on there. So parasympathetic again, pupillary constriction, increased saliva production, decreased heart rate, bronchoconstriction, increased secretions, motility, and relaxation of the anal sphincter, urinary system, increased renal filtration, increased urine output, urethral sphincter, the internal one relaxes, reproductive system, increased secretions, increased blood flow. Now, sympathetic nervous system, so in the eye, so we're going to have sympathetic nerves traveling up with the oculomotor nerve, but they're separate nerve fibers. You'll learn this when you talk about Horner syndrome. These cause pupil dilation and actually causes some retraction of the eyelid, which makes the eye open up more, okay? So the pupil dilation is going to increase light coming into the eye, which can help with visual acuity. So decreased saliva production, sometimes even like thicker, like mucousy saliva, so dry mouth when you're nervous, that sucks. Heart rate, increased heart rate, but also increased contractility. That will be worked out when you get to the cardiovascular system. And the airways will have bronchodilation. We need more air coming into the lungs because we need more oxygen to pump around the body with our increased heart rate and contractility, which increase cardiac output, to increase oxygen delivery to the muscles, which should be working because you're either exercising or running from something like a bear. Digestive system, decreased secretions, decreased motility, decreased blood flow. Urinary system, decreased filtration because of less blood flow to the kidneys, which will decrease urine output, and the internal sphincter contracts, just like the internal sphincter and the anal sphincter is going to contract. Reproductive system, decreased secretions, decreased blood flow, unless you're already reproducing or sexually active. Well, then we need some sympathetic outflow at the end to produce orgasm. So every textbook talks about that because it's just an example of the parasympathetic nervous system working together. Okay, whatever. The adrenal glands, so this is unique to the sympathetic nervous system. Sympathetic nerves will go to the adrenal medulla and cause release of epinephrine. So this is why when you're pissed off or upset or worked up or have a bunch of sympathetic outflow, even if you're exercising, it takes some time to fully calm down. You can go from completely calm to super pissed in seconds, but you can't go from super pissed and upset or all worked up to calm in seconds. So it's because epinephrine has a 3 to 5 minute half-life, somewhere around there. So it's going to take you 15 to 25 minutes to fully go through those 5 half-lives we talked about in class to kind of clear the epinephrine. Blood vessels, vasoconstriction, so sympathetic tone. So blood vessels do not have parasympathetic nerves to them. This will come back in the cardiovascular system. Only sympathetic nerves. So however active the sympathetic nerves are, will have a certain amount of vasoconstriction or sympathetic tone, and that affects something called the total peripheral resistance, which is one of the factors along with blood volume and cardiac output that affect our blood pressure. So that's it. That was spoken very quickly, right? So problems with the sympathetic nervous system, the example I always use, orthostatic hypotension. So orthostatic, when you go to stand up really fast, everyone's experienced it, you get a little dizzy. Why? Blood pressure drops because you decrease venous return to the hearts because of gravity, so there's less preload. So sympathetic nerves have to kick in to cause some systemic vasoconstriction and also potentially increase your heart rate to increase your cardiac output to make up for that lack of preload, I guess. So if the sympathetic nervous system doesn't kick in like it's supposed to, your blood pressure will drop a significant amount. I think it's like 30 points systolic or whatever to be considered orthostatic hypotension, and people pass out and hit their head because there's not enough blood flow to the brain. So temporary low blood flow to the brain's really good at auto-regulating its blood flow, but if your pressure drops too low, well, it can only do so much. Okay? So hopefully that sums it up. Very quick video. Slow it down if you need to. or replayed a couple times. I know you love listening to my voice. And there you go. There's some shitty whiteboards for your quiz next week.